Terra's innovation that allows us to talk about this treatment that now has been present for several years and is so widely used by so many of you. Now, the second unique approach is it had to be powerful, because if it's not powerful enough, it's not going to be targeted. And so they had to come up with a device that, as we all know, has this 100-watt power, again, that allows us to, with often selective shots, really destroy the sebaceous oil gland. As I'll show you in the subsequent slides, sometimes even with a single pulse, we can utilize it to really target these glands. Now, they also had to make sure that it matches the thermal relaxation time of the sebaceous oil gland. Again, another concept that goes all the way back to the physics of selective photothermolysis. And so, as you will recall, the thermal relaxation time is usually 60 milliseconds when it comes to sebaceous oil glands. So the pulse had to be shorter than that. And that is why when you study AviClear, you will recall that the pulse duration is 50 milliseconds. Again, very fitting for this device. But they also had to make sure that it's very safe. And so safety comes not only with being able to not target any additional structures, but being able to use it in a variety of patients. And so we know that when we use this device, the temperature within the sebaceous oil gland can rise very quickly. In fact, according to some, it goes all the way to 98 degrees Celsius, which is quite high and will certainly be not receptive when it comes to pain tolerance or even DE junction, dermal epidermal junction. So to mitigate that, they created contact cooling. In this case, sapphire cooling, which you know is present before the treatment, pre-cooling, during the treatment, post-cooling. And by doing that, you are able to, on one hand, create this very high temperature, 98 degrees, within the sebaceous oil gland, but at the same time, protect the DE junction, which, according to all of the preliminary studies with AviClear, stays under 50 degrees Celsius, which is so important. In addition to that, you're able to mitigate that very significant pain by, again, cooling the skin and keeping the temperature below 45, or according to some, 42 to 45 degrees Celsius. Again, something that makes it more tolerable. And lastly, as a result of this, unlike many of our other lasers, where we always say, be careful with dark skin because of the concerns with hyperpigmentation, as you know, a number of our laser devices simply cannot be used on darker skinned individuals, which frankly represents a very large proportion of population, certainly in my practice in Canada. But now we have a device, AviClear, which, despite being a laser, is very safe in all skin phototypes, regarding whether it's richly pigmented skin or not, based on all of the factors that I just mentioned: selectivity, contact cooling, and specific precision. And so that's what brought the concept, of course, of AviClear. As you all know, that has been approved for management of acne, regardless of the severity. According to sort of the initial approval, it's cleared for mild, moderate, and severe inflammatory acne. And according to the standard protocol, there's usually 3 treatments recommended 1 month apart. Now, this graph just reminds all of us why, when it comes to sebaceous oil gland, we will not be talking about wavelengths in the rest of the spectrum that you see here, because we only have a very narrow window, in this case, 1726 nanometer wavelength, which allows us to specifically target sebaceous oil gland, as opposed to this water absorption graph that you see in black, which is above the sebaceous oil gland in all of the wavelengths, with the exception of the 1726 nanometer, where you actually have twice as much energy absorbed by the sebum compared to water. So that is why, even if in 20 years we have competitor-based devices that are all trying to claim sebaceous oil gland, the wavelength will remain the same. And that selectivity, as you can see on the right-hand side, is what allows us to specifically damage sebocytes. Now, we have a number of studies, and this is one of my colleagues in the US, Dr. Bhatia, who actually presented at the ASDS meeting a variety of treatment parameters amongst patients who are undergoing some surgical procedures. And so they were able to use these treatments to actually induce changes within the sebaceous oil gland, and then after the surgery, excise the skin and see what happens histologically. And they used two different parameters, which of course are both present as part of your setting on the AviClear. On the left-hand side, you can see a relatively low fluence of 17 joules per centimeter squared. On the right-hand side image, a relatively high fluence of 30 joules per centimeter squared with a 5 degrees Celsius cooling. But regardless of either image, what we see is precision. And that is exactly what I was telling you when it comes to the concept of selectivity, where we see what happens within the sebaceous oil gland. We've got this sebocyte death and very specific necrosis. But despite that precision, we do not see any kind of inflammation in the rest of the skin histologically. So our epidermis remains normal. We see a very nice stratum corneum on top, and we don't see any extensive inflammation within the dermis, which reflects why this treatment is so safe clinically, as I'll show you in the studies, but also so well tolerated when it comes to recovery. And the patients literally wake up the next day and can move on with their life. And so this was a very important study that allowed us to understand that even at the high settings, it's very, very selective. And of course, most of you are familiar with the pivotal data that allowed the approval of this device, which now goes up to 1 year follow-up post-treatment. And just to remind you, this was a study of nearly 104 patients, 16 and up, who officially were allowed to enter whether they had mild or severe acne. They had to have a certain number of inflammatory lesions. But in reality, as you can see, nearly all of the patients were either moderate or severe. So essentially, they didn't really have any mild patients. Fairly significant inflammatory acne at 7 different sites throughout North America. Standard treatment protocol of 3 treatments 1 month apart. Now, in the case of the AviClear pivotal study, it was done as monotherapy, but as I'll show you, that is not necessarily the case in our practices. We can do a whole bunch of things now. But for the pivotal study, monotherapy and no pain mitigation. So they really wanted to ascertain how well it works, with the primary endpoint at the bottom being a response rate of greater than 50% reduction in inflammatory lesions, and with secondary points, including things like inflammatory lesion count reduction and nodule count reduction as well. Now, this is the setup of the study. You've got a bunch of patients. You've got a washout to make sure that they're all on the same page, baseline image collection, 3 treatments one month apart, and then you have a follow-up. And again, the primary endpoint was 3 months after the last treatment. And I think as clinicians, when you see this kind of study, you have to then gauge your own practices, because when we see our patients, you might want to see the effect immediately after the last treatment. But notice that even in the pivotal study, they had to wait 3 months at a minimum to ascertain primary endpoint. But then we now have follow-up data all the way up to 12 months, where we can actually see what happens in terms of the numbers. This is, once again, the type of patients that they saw. I mentioned already the age range, 16 and up, but we see a very nice distribution going all the way from 16 to even a small proportion of patients over 35, most of them being moderate, but a significant proportion, nearly a fifth, being severe, and a very wide variety of pigmentation amongst our patients, as reflected on what is shown here, the Fitzpatrick skin type. So a very applicable patient population. Those of you who are dermatologists will know very well that a lot of the traditional acne studies only include Caucasian population, which is really a concern nowadays, because again, our patients represent all variety of skin tones. And so the fact that this study was amongst the broad skin of patients really is important for us, both from clinical standpoint, but also safety as well. And these are the numbers. So remember that at the 3-month point, you had about 80% of patients showing significant reduction, more than 50% reduction in inflammatory lesion count, which of course was not only statistically significant, but led to this clinical approval. But look what happens as the time progresses. It actually gets better. And remember, those patients did not have any concomitant treatments. So it's a very telling sign as to what we should do clinically. If you wait up to 6 months, you rise up to even 87% improvement in this parameter. And at 12 months, it's even better. So it continues to improve even after the fact. And on this graph, we can see that other parameters follow the trend. So of course, the middle is what was the primary endpoint, 50% reduction. But for example, a lot of the traditional acne studies with prescription therapies look at the IGA improvement of 0 or 1, which is clear or almost clear. The scale is a 5-point scale where it goes from 0 to 4, 4 being severe, 0 being clear. So usually in acne studies, they look at things like proportion of patients who are clear, 0, or almost clear, 1. And you can see that at 3 months, when the study was kind of completed at the primary endpoint, you had 36% of patients, a third having clear, almost clear, which is a very stringent endpoint, and even compared to therapeutics is very impressive. But look what happens at 12 months on that left-hand side. You've got nearly double, 66% of patients showing that efficacy. So really, when you bring your patients back, whether it's at 1 month after the last treatment or at 3 months, you just have to be mindful that what they see at that point is not the end result. And it's always a spectrum where you have a proportion of patients who maybe are earlier responders, but even the ones that have partial response will often catch up if you just wait. And on the right-hand side, comedonal acne, which of course is whiteheads and blackheads, not as much triggered by the sebum inflammation, and in general is usually treated with topical retinoids, not necessarily AviClear. But look at this. At 3 months after the last treatment, you've got a relatively low proportion of patients responding, 13% of comedonal acne. But look what happens by 12 months. You've got nearly 40% response, which is actually very impressive considering that this is comedonal lesions. And again, just goes to show you that timing is everything when it comes to assessment. This is another way of summarizing the same thing that I just mentioned, again, showing you the progression of the primary endpoint from 80 to 92% and all these secondary reductions. But the biggest sign of all of this is the safety. And so what's really, really important to note here is that at 1 year, which is our, of course, long-term safety, there's really no instance of blistering, crusting, or hypo or hyperpigmentation. And when it comes to acne treatment with devices, although efficacy is key, and this is a procedure that is elective, you charge money for this, and of course, it's all about efficacy. But I would argue safety is just as important, and safety is a combination of both tolerability, short-term safety, and long-term safety, where the last thing that you want is to induce another problem, and certainly we're not seeing it with this device. This is more the short-term safety, where we've got a very standard transient side effects. All of our patients get a little bit red, a little bit of swelling, edema. Now, some of them might get a little bit of acneiform flare-up. Those of you who are in the field of dermatology, of course, very well know about, for example, the use of isotretinoin, agents like Accutane, Epuris, Absorica LD, where sometimes in the initial phases of the treatment, the patients actually have a flare, but over time it gets better. And so the very similar kind of effect may be seen in some instances with AviClear. I think the key is if you preempt it by discussing it with the patients, then your patients will know what to anticipate. And you can have dryness and itchiness, but overall, the majority of side effects are mild. All of the patients were able to tolerate it. And again, even from the short-term standpoint, there was no real safety concerns that I need to discuss. And we know it works. And so you've all seen these pictures. This is a baseline patient, moderate acne, 6 months after the third treatment. So really, it's about 9 months in, beautiful result. And at 12 months, it actually gets even better at that point. And even some of the scars are reversing. And that's actually very well known because if you study acne scarring, you know that although we always say acne scars are permanent, if you treat acne early on and reduce the inflammation, some of the initial scarring can be reversible as well just from the treatment alone. This is another patient who has jawline distribution. If you see it in a female adult patient, you will immediately use the clinical term of hormonal acne. She has this distribution along her cheeks and a little bit on the temple, classic inflammatory papules. And we can see that 6 months after the third treatment, already her acne is significantly diminished. She's getting milder presence. And look what happens at 12 months, just simply by waiting, no additional treatments, she's almost clear. And again, it can be replicated in all kinds of patients, all the way from fit 6 or your black skin patients on the bottom right to, of course, your lightest, most fairest skin patients on the bottom or on the top left, which is your fits 2, and of course, everyone else in between. And now I'll show you some of my patients. So these are very common types of results in my clinic. I can tell you a couple tricks. I think many of us who were early users of this device initially were not utilizing the entire pulse availability. And so I find that truly treating them with 300 pulses is absolutely essential. Sometimes physicians who are not getting the same efficacy, when you actually look at the settings, they're not utilizing the full pulse potential. Now, depending on my patient's pigmentation, I sometimes start them a little bit lower. So this is a very nice young Lebanese lady. She actually has tried a variety of treatments. Now, if you look at her, and those of you who are dermatologists in the some webinar today, you might consider things like oral antiandrogens, which I do as well. And so in Canada, we use a lot of spironolactone, typical dosage between 50 to 100 milligrams a day. We now have topical anti-androgen agents, including clascoterone or Winlevi cream that some of you will recognize. So she was given that, but she actually could not tolerate spironolactone because she's one of those people whose blood pressure dropped down. So she got some hypotension and it was not advisable. And Winlevi cream, of course, although is very well tolerated, was not really appropriate for her. Prior to that, she's tried antibiotics and some of the topical retinoids as well, just was not helpful. And then this is now, after 3 treatments, she's got beautiful result. You can see the treatment settings. We kept it fluence relatively low from what is possible, but she responded beautifully, and it's now been over a year since the treatment was done. She continues to do very well. Now, for maintenance, like many dermatologists, I have a lot of my patients on some form of a topical retinoid monotherapy. My preferred choice nowadays is our 4th generation gamma receptor specific topical retinoid, which is known as triferritine, or brand name AviClear, that I use either daily or several times a week. It has the highest efficacy for scar reduction out of all of the retinoids ever published. And so that's my preferred choice for maintenance. But nevertheless, she's done amazing, did not have recurrence. Now, this lady, another young lady, had a very severe inflammatory acne. And so if you show this to an audience of clinical dermatologists, the first thing that will come to all of their minds will, of course, be isotretinoin, some form of Accutane brand. And that's precisely what she did. She was given isotretinoin, but in the place where we live in Calgary, it's exceptionally dry. And so she had exuberant cheilitis and then started getting some of the other concerning side effects. Her triglycerides went up. And so she simply could not complete the course. And so she came to me from one of my colleague dermatologists in the city with a request to specifically consider laser. Prior to isotretinoin, she's also done systemic antibiotics, doxycycline, and some of the topicals. So it made sense to do laser for her as well. And so here you can see, because of her light repigmentation, although our initial treatment fluence was 21, we were able to actually bump her up to 23 joules per centimeter squared. And this was her result immediately after 3 treatments. But of course, as I just showed you, as the time progresses, it gets better and better. What's so impressive is when you see the degree of inflammation, you really start thinking that she's going to be the most scarred up person ever, which is often the case. But yet, when you see her shortly after completion of her treatments, you can see really that there's very minimal scarring. And I can assure you that whatever you see clinically on this image has actually resolved as well. And this is a very young lady who was 12 at the time that she came to us. She has East Indian background. And of course, to make life difficult, not only she's already quote unquote off label because of her younger age, but she also has parents who are both very accomplished. And to make matters worse, her father is a very accomplished neurosurgeon in the city. And of course, as you know, physicians expect a lot from these treatments. And her mother is actually a litigation lawyer, which from the compliance standpoint is very important, because the last thing that you want to do on a daughter of a lawyer is to use the device inappropriately. And of course, she has dark skin. So young, dark skin, lawyer mom, physician dad, and has already scarring acne. And so although, again, as a medical dermatologist who's very comfortable with a variety of treatments, I always do medical and cosmetic combined. We offered her all of the typical treatments that we would for a young person, including some of the novel triple topical therapies. We have Captrio, which is a combination of benzoyl peroxide, retin-A, as well as clindamycin. We offered a possibility of low-dose antibiotic, which was not of interest to them either. We went through all of these treatments, and they said, you know what, at the end of the day, we want the laser. And of course, we know that laser is safe in this population as well, based on what I just described, the pigmentation, but also the age of the patient. I've used it in a number of kids of this age. And ultimately, she did incredibly well, as you can see here. So this is, again, immediately after the 3 treatments. Those were the pictures. I just wanted to show you a good case. So immediately after, we kept her fluence a little bit lower than the other 2 older ladies. We started her quite low at 17 joules per centimeter squared, progressing up to 21, and she was able to tolerate it. But the bottom line is she's done very well. And we can see that even some of her comedones, if you look really closely, like some of her blackheads and some of the whiteheads, have significantly diminished. Now, of course, in her case, there is already a visible acne scarring. So she's the kind of patient that I immediately would start on both topical retinoid. In fact, as I'll show you, I now use it concurrently, even during the treatment. But in addition to that, if you have access to any kind of non-ablative fractional resurfacing, or if you have even devices like microneedling, she would be a great candidate for that. And of course, once she's older, if she still has scarring, at least in my practice, I do a lot of microinjection of hyaluronic acid-based products, the skin boosters, if you will, that we call them in North America. And so that could be useful as well. So at the end of the day, scarring is important, but first we have to treat acne. Now, that was all the pivotal studies in my own practice. But the real question is, can we do more? And so, we have this beautiful new innovative device, but we also have our standard acne treatments, therapeutics, prescription. And so is there a role for combination? That's question number 1. And is there a role for additional treatments in patients who maybe have not reached that full response? And so I showed you beautiful numbers that everyone sort of responds, but you might say in your real life, you might sometimes have patients who don't have as good of a response. Would additional treatments be helpful? And this is where this real world study came up, where combination treatments were actually utilized. And so several of our colleagues have looked at their patient population. So they specifically had 44 patients, and the patients were at baseline on either AviClear by itself or AviClear in combination with these concomitant medications that I'll show you. And so some of them were on topicals, some of them are on systemics, but they still underwent the classic 3 AviClear treatments. Now, similar to the original pivotal study, At 3 months, there was a sub-analysis done, and then they followed them up to 6 months after the last treatment. But if at 6 months post the last treatment, they still felt that the patient did not reach at least a 1 grade improvement on this acne scale, the IGA scale, then they allowed for additional treatments that were separated by 1 month apart until the patient was able to get to this 1 grade reduction. And so as a result, some of the patients needed none of the additional treatments, some patients maybe needed one additional treatment, and some needed more. And so this is the summary. So you have 44 patients, again, of a variety of Fitzpatrick skin on the left-hand side. You can see that the age range was 16 to 43 years of age, most of them moderate acne, but proportional with severe. So very similar to the pivotal study. But what was different is that nearly half of the patients, 21 of them, were on concomitant acne medications. And if you look at the wheel on your right-hand side, you will see the kind of medications that they're on. Now, again, for the dermatologists in this webinar, of course, all of the dermatologists prefer to use as the initial treatment some form of a retinoid, either monotherapy retinoid or combo. So it's not a shocker that the largest proportion of patients, 36%, were on a topical retinoid of some sort. And of course, a number of them were on combos as well. Now, sometimes, if a patient has retinoid sensitivity, and other choices are made, and Dr. Fromovitz, who is one of the original presenters on the study, and colleagues sometimes used combos. And so they used, topical antibiotic combo, 29% of the patients, topical retinoid with antibiotics, small proportion. Some of them were on oral antibiotics as well. We know in dermatology that's used for short periods of time. Usually we prefer to stick with 3 months or less. And then you had some hormonal treatments, including agents like spironolactone, which of course are commonly utilized, and a very small proportion of patients were on supplements. Now, look at their results, okay? So after the 3 treatments, when they waited 6 months, post the last 3 treatments, they had 73%. So most of the patients had at least a 1 grade reduction when it comes to their acne improvement. But when they followed them up to 12 months, and some of those patients had additional treatments with AviClear, if they didn't have enough response, you have nearly 100% of patients showing improvement. And really, when it came to satisfaction, you have a 76% rate of satisfaction. And in order for me to demonstrate the patients that did or did not need treatments, I wanted to show you a couple clinical examples. So this is a 26-year-old female. At baseline, she has an IGA of 3, which is graded as moderate. We can see that after 3 treatments and waiting another 12 weeks after the last treatment, so about 3 months, she's already clear. So of course, extremely satisfied. And she continues to be followed now at 6 months, 26 weeks after the 3rd treatment, still clear. And then 1 year after the last treatment, she's still clear. So she did extremely well. Now, she was, in addition to all of this, from the baseline on concomitant medications. Again, these might be not your choices or my choices, but that's what she was given. So in the middle, BPO clindamycin. So in Canada, at least, we know this as clindoxil or benzocaine gel. In US or Australia, you might have some equivalent name. She was on dapsone gel or axone gel, which I used to use a lot in my practice. I don't use it anymore, but it is a kind of second, third line treatment as an anti-inflammatory. And she is on an oral spironolactone, which, as I mentioned, I do use on a lot of my adult female patients, especially the ones like her who have this jawline or mid-cheek distribution. So she was concomitantly treated with appropriate therapies, therapeutically, but also laser, did extremely well, did not need any additional treatments. Beautiful result. Now, this patient is a little bit different. It's also a female, in this case, 34-year-old, but she, as you can see at baseline, had moderate acne, IGA of 3. And then after the 3 treatments and waiting another 26 weeks, so at 6 months after the 3rd treatment, she's better visually, but when you actually grade her, she's still moderate. So she's still grade 3. So she didn't really improve that much. So at that point, based on the protocol, they were able to use additional treatments. So they decided to do 2 sequential AviClear treatments, and that's why you'll see that on top it says 5 treatments total. And we can see that 12 weeks.
Sorry, I don't understand.
12 weeks after the 5th treatment, she's already significantly improved. And so she goes from moderate to mild, extremely
Welcome
satisfied.
to the webinar.
And then
You have
1
entered
year
as an
after the
attendee
5
in listen-only
treatments,
mode.
she's actually clear. So she's the kind of patient that benefited from additional treatments. Now, she was also on concomitant medications. In this case, she was on a very generic topical retinoid, tretinoin cream. She was given clindamycin for some of the inflammatory topically, and she was given spironolactone as well. So combination therapy patient, but you need to target it from every angle. Not sufficient response after 3 treatments. Wait 6 months, not enough, and then do additional 2 treatments, did beautifully. And so as part of that assessment, when Dr. Fromovitz looked at the study, although there was not necessarily always a statistical significance between adding adjunct concomitant medications or just doing AviClear by itself, there was clearly a trend. And based on that trend,